Hello, everyone, and welcome to our webinar discussion today, Medicaid at Risk Part 2, Navigating the Path Forward Together. I'm very grateful to be joined today by a really terrific panel of speakers who are bringing a wide variety of expertise to the room. I'm Stephanie Anderson with the Clark Fox Policy Institute here at the Brown School at WashU. We're very happy to help host this webinar today with our partners at the Community Health Commission. This webinar will be recorded, so you'll see that that's gotten started already. And we will be sharing a copy of the recording on our YouTube channel for the Brown School after the session today. So we can look for that if you'd like to share or watch it again. If you have questions for our panelists today, please use the Q&A function in Zoom to ask your question, and they'll be taking questions throughout the discussion today. So we'll be returning to those often. Please post your questions there. You can also use the chat for discussion as well. And I will go ahead and turn it over to Rob Gibson with the Community Health Commission to kick us off.
Thanks so much, Stephanie. Thank you for allowing us to partner with you to host this important discussion today. We're excited for all the attendees that we have. And again, we want to give many thanks to our panelists for making themselves available again for this time of discussion. Before we jump into the panel, I would like to turn it over to our CEO, Risa Rollins. Risa is going to offer a welcome to all of our attendees, and then we'll get started. With that being said, I'm going to pass it to Risa.
Awesome. Good afternoon and happy Friday, everyone. We're that much closer to the weekend, but we have some important work to do and some really important conversations to have before then. As Rob mentioned, I am Risa Rollins, CEO of the Community Health Commission of Missouri, CHCM. And truly, thank you for joining us for part 2 of our Medicaid at Risk Town Hall. You have many choices of what you can do with your Friday afternoon, and I think this is testament to just how important this conversation is. So we're deeply grateful for you joining us this afternoon. I want to give a special thanks, of course, to the Brown School at Washington University for co-hosting this and for always being gracious and willing partners and getting folks into the room. Special thank you to our very busy panelists who are joining us this afternoon and have really been doing yeoman's work in helping to keep this conversation top of mind and not just talking about it, but planning on what we can do about it as well. Thank you so much for our community members across Missouri who continue to show up, to speak out, to stay engaged, to not grow weary in the conversation or to become so overwhelmed and frustrated that we decide that we are going to just kind of do the ostrich thing and cover our heads in the sand. So thank you for continuing to show up and staying engaged. You know, at CHCM, our roots are in community advocacy. That is our bread and butter. That is the thing that we love, that energizes us, that brings us on fire to work every day. We were created to serve as a bridge between systems and the people that these systems are meant to serve. This legacy grounds our approach to Medicaid defense. So now we know there's a lot that's been happening. The news can be overwhelming. HR 1, though, is not just about dollars and data. To be clear, it's about real people. It's about the moms navigating postpartum depression without behavioral health care. It's about the rural elder who now has to drive 60 miles for a checkup. It's about our immigrant neighbors who are locked out of coverage altogether. We're not defending a program. We're literally defending people's lives, dignity, and futures. So today's conversation is an opportunity for us to collectively examine what HR 1 means for Missouri Medicaid, to uplift the voices of those who are directly impacted, and to coordinate our strategies to respond together. So again, thank you to our advocacy partners, Missouri Foundation for Health, the Missouri Budget Project, Legal Services of Eastern Missouri. Tim McBride has been doing this work for years, has the headlines to prove it. But this is not the end. It's a moment for us to pause, to reflect, and to re-energize. And with that, I'll turn it over back to Rob Gibson to introduce our panelists.
Thank you so much, Risa, for that encouraging and inspiring welcome, for setting the stage for our conversation. So with that being said, without further ado, I will jump right in. I'll introduce myself again. My name is Rob Gibson. I'm the Director of Policy and Advocacy here at the Community Health Commission of Missouri, affectionately known as CHCM. And again, we're happy and grateful to have you here today and for your time with this conversation. As Risa mentioned, we have a wonderful group of panelists here with us today. I'm going to give a brief introduction for each of our panelists at this moment in time. Our panelists for today are Amy Blouin, who serves as the president and CEO of the Missouri Budget Project. Thank you so much, Amy, for being here and for all of your dedicated leadership and service to the communities of Missouri. Next, we have Earlene Bolton. Earlene serves as the Senior Outreach Coordinator for Legal Services of Eastern Missouri, where she works in community with community to understand the needs of community. And so, Earlene, we really appreciate all that you do for our communities as well. Next, we have Dr. Timothy McBride, who serves as the co-director of the Center for Advancing Health Services, Policy and Economics Research at WashU, where he also duly serves as the head of the Rural Health Policy Lab. Tim, as he likes to be affectionately known, as humble as he is, we appreciate you for being here, sir. Thank you for your leadership and commitment to this work. Last but certainly not least, we have Sheldon Weisgrau, who serves as the Vice President of Health Policy and Advocacy at the Missouri Foundation for Health, affectionately known as MFH. Sheldon and his team do a great job under the leadership of Dwayne Proctor of supporting many of the communities and nonprofits across the state. And we really appreciate their continued partnership and support of this work. So thank you, Sheldon, for being here today. With that being said, let's kick off with our first question. And I think a great place to start is, since our last conversation, we know that there has been a big update, and that big update is that House Rule 1, HR 1, was passed in DC on July 4th. And last time that we talked about potential implications of that legislation as it pertains to Medicaid. So my question to the panelists is, please highlight for the audience and for our guests, what has changed or different about what we were looking at previously for that legislation, and what are the big things that you would like to impart on them around this legislation and how it's going to impact not only Medicaid, but other health services in the state of Missouri and across our country. So with that, we'll start with Tim.
Thank you. It wasn't unmuted, but it's such a great panel, and I really appreciate the invitation. And great to see you, Robert and Risa, and my panelist friends. And Stephanie, thanks for hosting this. And what has changed since we last talked? It's the parameters of the bill are largely the same, but probably worse. I think as it worked its way through from the House to the Senate, I think some of us had hoped it would get a little better, but I think it got larger and worse in terms of Medicaid cuts. So I think that's one message I would like to say. So I think the main parameters, as we'll kind of elucidate as we go through this, are important changes to work requirements, enrollment, in validation, recertification, provider taxes, and more. And the one addition that happened at the end, which we can talk about if you want, I have probably a lot to say about, is the Rural Hospital Transformation Fund, which was thrown in as, I think, sort of ballot candy to try to get a few extra votes at the end from some legislators. So the implications of that are to be followed, I think. So I think the important things is, and I know Amy and Sheldon have good numbers on this, so I'll turn it over to them as to what the real world impact will be on Missouri and our important residents and the budget.
Thanks, Tim. Any of our other panelists, would you like to share? Let's pass it maybe to Amy.
I saw Sheldon was coming off mute too. So, the gist is we expect 170,000 Missourians to lose healthcare because of the Medicaid changes that are including work requirements, but also the recertification requirements, the increased barriers and burdens that people will face in just trying to access somebody at DSS who can approve their application for coverage. I think that's going to be, there are things that we can do to mitigate the harm, but that's the biggest impact that I see of the bill is that loss of coverage for so many people. The other thing is that we know that there were restrictions on what's called the provider tax, and the provider tax is one of those essential ways that we raise money in the state to fund Medicaid. That's cut nearly in half, not quite, but nearly in half our ability to fund Medicaid. So that means that we're going to have to look at either increasing revenue somehow, state general revenue through taxes, or we're going to have to make cuts that are going to impact everybody who remains eligible for Medicaid. So I think we've got a lot of work to do. I think there are opportunities, but it's going to be hard.
Yeah. So thanks for that, Amy. So I would only add a couple of things to that. One is that if you look back in history when states have had budget crunches around Medicaid, one of the first things they do is they look at optional services to cut. So Medicaid has a set of mandatory services that every state must offer and a set of optional services. And most prominent among the optional services are home and community-based services for people with disabilities. Those are services that are designed to keep people in their homes and in their communities and out of institutional care. And they generally are among the first things that states look to cut when the budget crunch comes. The irony in that is that those are services that save money over the long term because home and community-based services are less expensive in the long run than nursing home and institutional services are. So I just want to flag that. Another thing is I want to make sure we don't forget about SNAP, the Supplemental Nutrition Assistance Program, which is having a lot of costs shifted from the federal government to the state, which is going to have added budget implications where Missouri is going to have to come up with hundreds of millions of additional dollars. And the third thing I'll note is that the way the law is written, a lot of the cuts are designed to not take place until after the next election in 2026. Which on the one hand, you can look at it cynically and say they were trying to protect themselves and not put the cuts in. You could also look at it and say that gives us some time to really press for changes and improvements. And so before the hard times really hit, we may have an opportunity to do some advocacy and get some things changed.
Thanks, Sheldon. I really appreciate that overview and highlights of the bill and potential impacts. Earlene, did you have anything you wanted to add before we move to the next question?
Sorry, couldn't get off mute. No, I think the panelists did a great job of highlighting the bill. Definitely worried about the coverage losses, the additional administrative burden on the state agency that is already just kind of operating at full capacity, but not able to do it well because they don't have the staff. And so when you add additional administrative burden, you see more families lose coverage. And then even though the work requirements primarily impact the expansion population, it will have ripple effects on coverage for children. Research does show that when parents are covered, their children are more likely to be covered. But if parents are experiencing a lot of strain with the Medicaid system, just keeping their coverage, they're more likely to not want to interact with that system at all.
Thank you, Earlene. Appreciate that additional context. With that being said, before we move to our next question, I just want to remind everyone what Stephanie mentioned. If you're just joining us, as my colleague Joy just put in the chat, We welcome your questions at any time during the discussion. So feel free to ask. There's a Q&A chat box you should see at the bottom ribbon of your screen at the very bottom. It says Q&A. You could click there, put in your questions if you're able. And if you are not able to do that, we will have a period of time at the end of our panel where we will allow folks to be able to come off mute and be able to ask questions if that works for you as well. We just wanted you to know that you can stay engaged or ask your questions at any time in the chat and we will get to them. So with that being said, I will move on to our next question. So let's talk a little bit more about work requirements and some of the additional challenges that HR 1 will pose for folks as pertains to maintaining eligibility for Medicaid. Specifically, how will the new work requirements and increased frequency of eligibility redeterminations impact Medicaid enrollment, particularly for vulnerable populations and those enrolled through Medicaid expansion, as Missouri is one of the states that did both through our initiative petition process through the voters to expand Medicaid. I'll let Sheldon start us off with that.
Okay, thank you. Well, it's a big question with a lot of moving parts, and so I will start and then hand it to my other panelists to fill in. And so I'll try to start with context and big picture first. And so the key change to eligibility that the bill makes is that it requires people who are eligible for Medicaid through the expansion that took place just a few years ago, which are adults ages 19 to 64, requires them to document that they're working or volunteering or going to school at least 80 hours a month to remain eligible for services. And the problem with work requirements, and I want to be really clear about this, nobody is against work. And the fact is that the large majority of people who are on Medicaid are either working or unable to work for a particular reason. And that's really where the rub is. And so Earlene mentioned earlier about the issues that the state has administratively in determining eligibility for folks in the current system. Work requirements add a huge layer of complexity onto that. And so ideally, the state is going to pull from state records that already exist to document that people are working. But in a lot of cases, those data systems aren't linked or the data isn't there. And so they're going to have to ask beneficiaries to prove that they're working. That's going to require people to upload documents. It's going to require people to collect pay stubs, whatever it is. It's going to put people in certain situations in a really difficult position. How does a farmer who runs his own family farm demonstrate that he's working? He doesn't get a paycheck. And so just the level of complications in documenting work really concern me as to how the state of Missouri is going to ask for compliance with that. The second half of that is because we're talking about Medicaid, we're talking about a population that has a high level of disabilities, people that are sick and have illnesses, some people that are aged. They're going to have presumably exemptions from the work requirement. But again, they're going to have to demonstrate that they meet an exemption. And how that process is going to happen is really unclear. And it's very evident that at this moment, the state does not have the capabilities in place to do that documentation. It's going to take a long time and a lot of money to get that into place, and it's just not clear that that's going to be available. And with that, I will hand it off to whoever wants to pick up.
I'll just jump in real quick and just agree with what Sheldon said, and Earlene brought this up earlier, and Sheldon elucidated that. I mean, a couple of points about the work requirements. Of course, we all agree if a person can work or provide community service, that's great. The evidence shows in our state that we've produced, and also Kaiser's produced nationally, that about 2/3 of people on Medicaid are already working in this age group. So that's really important to point out. So they're part-time, and full-time. The remaining ones, many of them are not working due to disability, or they're caregiving, say for a young child, or they're going to school. So when you break it down to the number of people that'll be affected, it's on the order of about 10%, which is not very many. But and some people said, well, it's not going to affect very many people, but it's going to affect everybody, as Sheldon just said, because they all got to report whether they're working or doing this community service or not. We already know that the state is having difficulty just doing what it's already asked to do, which is one time a year re-verify that a person's enrolled. And the data that I track with a grant with MFH and is reported pretty widely shows that in the recent unwinding, about 26% of people were lost their coverage, and about 80% of those were for procedural reasons. It wasn't because they were ineligible. It was because somehow they got lost in the process, because maybe they didn't get the form, maybe they turned it in, it didn't get received, maybe a whole host of other reasons. Maybe they didn't understand the form, maybe they thought it said they're still on Medicaid. There's a whole host of reasons. And alarmingly, I think the data is actually getting a little worse in the last few months, but this is a time-sensitive thing, so who knows what it'll look like. But what I'm concerned really about is that, among many things, is that our state is already short-staffed and underpaid, and we're going to ask them to do about 4 times as much work as they're currently doing, because instead of verifying once a year, we're going to have to verify twice a year, and then we're going to have to verify that they're satisfying this work requirement. And that's just a lot of choke points where things could go wrong, and that's what's worried me, in addition to many other things. I'll stop there.
I'm just going to build off that and actually answer a couple of the questions in the Q&A if I'm jumping ahead here. But there's a question about, are individuals with a mental health issue or substance use disorder, are they exempt? So the bill did include a provision that folks in substance abuse treatment are exempt, but only for 90 days. And again, you have to prove that you're in treatment first to be able to get the exemption. But there's a broader host of folks with mental health conditions that are not substance abuse related. They may not be actively in treatment. They're not going to be able to work. They're not going to be able to prove an exemption just, off the bat, but they're going to lose health care at a time when they need it the most. There are things that we can do to mitigate that, and ways that we can work with the Department of Social Services. And again, this is jumping ahead, but how do we, help the department give automatic exemptions to folks? That's one of the things that we're looking at right now, is how can they flag people who it's clear have a mental health condition and shouldn't have to go through all of the hoops, right? So, and this is just one example. So there are people, tens of thousands of folks who receive Medicaid who are also clients of the Department of Mental Health. Those folks should already, automatically be exempt. There are codes that the managed care organizations use when they are paying for the treatment that folks get, paying providers for that treatment. And those codes could be things like, certain prescription medications, counseling, anything that indicates that folks have a mental health issue would take them right into an automatic exemption. But, again, it's going to be, can we set up the systems, put them in place with the state to make sure that we're streamlining as much as possible? And that's going to take an investment, which Missouri has not done yet. It will require some work.
And I'm going to kind of jump in here and add, because there have been hearing conversations around the navigators, which have been really, really helpful to help folks enroll and to help reduce the churn. And dovetailing into this is the loss of, 90% of our funds. So all 4 of the federally qualified health centers in St. Louis have lost their funding to provide that resource. So not only do we have this increased bottleneck and barrier, at the same time we're rescinding the things that we know from experience have actually worked to help us inform, educate, and connect folks to these services.
Yeah, and if I could just add, I mean, that brings me back to something. I mean, if you listen to the rhetoric when the bill was being passed, there was a lot of bad-faced arguments about young men sitting at home on the couch playing video games and collecting Medicaid. First of all, people don't collect Medicaid. Nobody gets a check from Medicaid. The payment goes to healthcare providers that are providing services. But beyond that, a work requirement gets the relationship between health and work exactly backwards. You need to be healthy to be in the workforce. There is actually a large body of academic research that shows that. And so when you say to people, we're not going to let you get the health care you need to get well enough to be a productive member of the workforce, we're really just cutting them off from ever making that possible. And so when I talk about bad faith and cynicism, that's what I'm talking about. If Congress was really serious about getting people productively into the workforce, they'd find ways to get people health care. They would not find ways to cut health care off from people.
And one more quick thing I'll add to that, I 100% agree with all that. And again, it's a small sliver of the people that are either not working, that are either already working, disabled, can't work, caregiving, whatever. Small sliver that are in that pie that apparently people are worried about, but they also have to be able to find a job. And as we sit here today, we got a pretty bad jobs report, and we haven't seen the way it's distributed across Missouri. But I'm worried that some of these Medicaid recipients that are going to be saying, "Well, how come you're not working?" You have to be able to get a job, and you have to have the skills to get the job. And so I would be happier if the state were to sort of help people get a job, but there's nothing in this bill that helps people get a job.
Thank you all for that robust conversation, and thank you all for your questions. Asia, I see a couple questions in the chat that just came in. Additionally, I think we may have covered this first one. Do you mind reading it for us, Asia, around folks living with a disability?
Yeah, so the first question is, can you summarize how HR1 affects individuals living with a disability, intellectual or otherwise, in their ability to receive Medicaid?
Well, just with the pregnant pause there, I'll just sort of jump in that, as we mentioned earlier, that while somebody may say, well, this doesn't directly affect the people with disabilities, they're protected. I'm worried that might not happen because they'll fall through the safety net cracks, because we know from a lot of evidence, for example, that the expansion population has a lot of people that are signing up for the expansion they're also checking a box that's saying they're disabled. But it's just that expansion is a better way to get their coverage. And that's one way I'm worried about that. And if you then sort of say, well, you can only get the coverage if you're working or doing community service, again, it's a hoop you have to pass through. That's one way. But, the broader thing that I think, frankly, I would bet most of us on the screen are worried about is the secondary effects. So the budgetary effects of the provider taxes and the other things on the state budget that Amy is the expert on. And, as that plays out in the state budget, and Sheldon mentioned the optional services, if the state starts running short of money, which is probably likely to be the case, they may cut services that help people with behavioral and developmental disabilities and other disabilities. And so I'm worried about that.
And I would just add, I just want to reiterate, the way the bill directly affects everybody in Medicaid is it requires that they go through an eligibility process at least twice a year instead of once a year. And we just know that every time the state reaches out to ask people for data to demonstrate that they are eligible for Medicaid, there's a lot of friction there, and a lot of people can't jump through that administrative hoop for a variety of reasons, which are often not their own fault. And so we are just going to lose a lot of people just because of that administrative runaround that's going to be increasing. And that's a direct impact on everybody in the program.
Thank you all for this. Oh, go ahead, Earlene. I'm sorry.
So I was just going to add briefly to kind of highlight more of what Tim and Sheldon, as well as Amy, mentioned with the exemptions. While they do have those exemptions, as Amy quite eloquently stated, our system really doesn't have a way to flag those appropriately. But we also have to think about those individuals in the expansion population who may feel that they're disabled, but they can't meet that total permanent disability exemption. And a lot of individuals have mental health needs, and those often don't meet that exemption, but them having expansion Medicaid has allowed them to function in society and work, as well as even if you just have chronic health conditions, as long as you're able to take your medications and go to your providers, you're able to function. But when you start adding things like work requirements and people losing coverage and they can't get the exemptions because they're not considered total permanently disabled, you're just kind of adding more strain on the health system. And that's why I wish the rhetoric was different, because Medicaid is for working people. As we know, the data shows the majority of individuals receiving Medicaid are working. But when you have this type of rhetoric, it just exacerbates a lot of things. It just creates more problems.
Amen.
Yeah, thank you, Earlene. That's a great point. And along those lines, that's a great transition to our next question around how the cuts to Medicaid will affect not just eligibility, but the financing and delivery of systems impact when it comes to access to care, as was mentioned, particularly for marginalized and rural communities. Along those lines, what are potential consequences for specific services like long-term care, behavioral health, and maternal care? And we can start with anyone. We can start with Amy. You can start with that question.
Okay, so I'm going to sound like the Grim Reaper right now, but Missouri already is projecting a budget shortfall. We're looking at having $1 billion cliff, and that's going to be hard to fill in and of itself. And that's before you take all of the federal cuts into account and these restrictions on how we can raise money to support Medicaid. So it's going to take, some work, and I think it's going to be painful. But if we don't come up with solutions, what I am concerned about is that, we have research that Missouri Foundation for Health has done, projects that we will lose about $20 billion over a 10-year period in federal funds to support Medicaid for the state of Missouri. We won't have the ability to make that up for providers. And that means that providers, particularly those that are running on slim margins already, all communities, but everywhere, we providers who don't have major profits, right? Mental health providers, community health clinics, rural hospitals, we're going to see those close. And that means everybody is going to have to go much farther for care that may be urgent. If you're having a heart attack, having to go 2 counties away is going to make a difference in terms of whether or not you survive. I think we are looking at a really difficult time.
And I'll just add to that. When I'm often asked this question, I'm an economist, so I say that spending on one person's part is revenue to somebody else. So I'm always most worried about the patients and the recipients of this program, because they're going to be the most directly harmed. But every dollar that's not spent on them is a dollar less that a provider gets. That means hospitals, that means doctors, that means mental health providers, that means a lot of people, and that means in rural and urban Missouri. And they're going to be that $21 billion that Amy talked about is the direct effect. Now there is a 1 billion apparently rural health hospital transformation fund, which has been brought up to sort of counteract that, but you can do the math. 1 billion ain't 21 billion. So it'll help to counteract that. And we already have a lot of rural hospitals that are, close to being closed. We've seen a couple in actually St. Louis area that have closed recently. And so, that's I'm worried about all the providers as well as the clients. And, we know what happens when people don't have Medicaid. They become uninsured and they still seek care. And that uncompensated care is a cost that the providers have to carry.
Yeah, one thing I would add, so thank you for that, Tim, because you made one of the points I wanted to make. But, if we zoom out, this isn't really all that complicated. There's only so many things a state can do when they face a Medicaid shortfall. They can cut eligibility for the program, meaning fewer people get Medicaid. They can cut the services that they fund, so the optional services as an example of what we were talking about before, or they can cut what they pay to providers. Or they can raise more money. But as Amy has made pretty clear, that is very difficult to do in Missouri. And so we are going to see likely all three of those approaches when the budget crunch really hits. So we're going to see fewer people in the program. We're going to see fewer services that are covered. We're going to see lower payments to providers. And all of that is going to have sort of the negative economic cascading effects that Tim has talked about.
Yeah, great points all around by everyone. And I think we have, with that being said, I think this conversation percolated a few questions in our Q&A box. I'll turn it over to Asia for us to try to answer one or two of those before we move on.
And one of these questions is kind of like, we'll answer a couple of questions actually. So, because someone recently asked, how will pharmacies be impacted? But this other question is, can you explain the implementation time? If we are a pharmacy or a clinic, when will we see decreased reimbursements according to the timeline?
So that's hard. It's a little bit of a moving target still. I posted a fact sheet that we put together in the chat that has an image of a timeline in the fact sheet on the second page. But I'm pointing that out because it's hopefully helpful. But because there are a couple of things. The work requirements are at the end of 2026, but states can apply for a waiver to delay that for 2 years. And that's one of the things that I hope that Missouri will do, delay that implementation. The cuts in terms of our ability to raise revenue through the provider tax, those would start in 2027 and be phased in over a few years. So it's a moving target. We are hoping that those will be delayed, and it's going to require advocacy with Congress to either delay or eliminate those cuts altogether. But in the near term, Missouri, because we're already facing a budget shortfall, state lawmakers know that this federal bill already happened. We're going to have to be vigilant about state level advocacy to prevent state lawmakers from making cuts preemptively, to the program. I am really worried about that in the short term.
One other thing I'll add to what Amy said, and I couldn't agree more. In terms of that timeline, it's a difficult question to answer because it's a 1,000-page bill that was passed, and there's a lot of different pieces in it. So, but I want to point this out just because I think if we want to be doomsayers, let's throw this one in there. At the end of 2025, the current thing that's going to happen is possible end of the enhanced premium tax credits for the Obamacare marketplaces. They could have extended that in this bill, and they chose not to. Congress still may do that. I'm pessimistic they will. We have over 400,000 people in Missouri on those marketplace plans who are low-income people that are just above the eligibility level for Medicaid. Most of the people in those that get those enhanced subsidies are between 100 and 250% of poverty. All the indications are that the premiums are already going to go up by 25% before the enhanced premium tax credits, maybe 75 to 100% after the tax credits go away. And so people are going to drop their coverage. That's why CBO said 4 million people across the country are going to lose coverage. And we're going to see tens of thousands of people drop their marketplace plans if that goes into effect. So I just add that to the timeline because that may be one of the first things that happen.
Thank you all for that insight and input, and for giving more context to the impact of these cuts to our systems and how it will affect folks' ability to access resources that are needed. With that being said, I think it's important to discuss how these cuts not only are going to affect our residents' access to care and services, but how this is going to create challenges for our localities and our nonprofits. Specifically, how can states and the federal government work together to minimize these disruptions to coverage and ensure a smooth transition? And also, what are the implications of the increased administrative burden on states as it pertains to the work requirements and other frequent redeterminations, or another way of saying that is the eligibility requirements?
So I'll start with that one. I think all of us that are on this panel today spend a lot of time both together and as individuals and as members of our organizations doing what is known as administrative advocacy with the state government. That is working with state government either cooperatively or trying to lean on them to get them to run programs more efficiently. And again, I think if you listen to the political discussion, which a lot of time focuses on big government versus small government, I think what we could all agree on that we want is good government. And part of good government is running programs effectively and efficiently. And so I think there's a role for everybody to do administrative advocacy and make their voices heard to state officials to try to keep their eye on the ball in making sure that these changes are implemented as seamlessly as possible. At the same time, that's difficult for them to do in an environment where they're under-resourced and underfunded. And that will require advocacy at the legislative level to get the legislature really for the first time ever to adequately finance state government agencies to do what we ask them to do.
Thanks, Sheldon, for that context. Would anyone else like to add on?
Yeah, I would. So I think there are several things that we can do in terms of advocacy. One that, that Sheldon mentioned about the administrative advocacy. I also think it's really going to require all of us, whether we're individuals with, Medicaid stories and how these cuts could affect ourselves, and providers with provider side stories and how that will affect the people in the communities that providers serve. I think everybody needs to be lifting up stories to our federal legislators and our state legislators that show concerns, that document cuts when they happen, and the impacts when they happen. And we're all going to need to be ready to advocate loudly for protecting Medicaid at the state level, fixing some of the disaster that Congress created, at the federal level. And we're going to have to be willing to advocate for revenue solutions too. That's, all of it ties together into a really extended advocacy strategy.
One thing I'll add to this is to try to, I 100% agree on the stories, try to get our state leaders and others aware of the cascading effect of all these changes. So, it's not just HR1. I already pointed out what's going to happen to the marketplaces, but there are the food stamp effects that are in HR1, but there's also the nonprofit organizations you talked about. I don't need to tell the people listening on this call, they've already taken an impact in terms of cutbacks in federal and state funding. And I know public health agencies are struggling. A lot of nonprofits got money pulled back. And so you take those organizations that are helping, that are already sort of short funded and short staffed, and then they're going to be asked to do a lot of the kind of work that Earlene does at Legal Services, who is their heroes in my book in terms of helping people. And that's just one example. So there are already, it's the unintended cascading effects, or I don't know if they're unintended, but they're cascading.
Thank you, Tim, and Amy and others for those comments and context. You mentioned Earlene. Earlene, not to put you on the spot, but we also like to get your insight, being that you are, like so many of us, working on the ground and working in community. Did you have anything you wanted to add?
Yeah, I just wholeheartedly agree with everyone's comments, especially Amy, about the elevating the client stories. I've done and still do a great deal of work of collecting client stories around their lived experience with Medicaid, but this is a time to really use that for advocacy in all aspects, especially around the state allocating funds, so that if we're going to have work requirements and more administrative burden, then you need to allocate the funds so that these systems can run properly, so that you are not causing poor health outcomes for your constituents. When you think about how poorly our systems run already, it can be very complex to flag exemptions and have people upload their work and things like that. So I think the stories are going to be really a strong point of advocacy. And unfortunately, we may have to collect those stories of how constituents are impacted when these systems don't work once they're implemented. But we can use stories now for advocacy to show how important Medicaid is to constituents and why it's important to start now with getting these systems up to date, so that we are not causing gaps in coverage and adding to the burden of our health centers and potentially increasing uncompensated care, which further strains the system.
Great point, Earlene. And
I want to jump in really quickly.
yes.
Because this is near and dear to my heart when we talk about storytelling and making sure that we're not just talking about numbers, but we're contextualizing and making sure that we are connecting real lives and experiences to the numbers that are telling a really horrible, stark story. The other thing that I think folks have been really savvy about is finding the sweet spot, right? So what are the stories that will perk folks' ears up, that they'll be more apt or prone to listen to as well? I was in a really interesting conversation that has my mind turning in another direction and thinking about some of these connecting points. We know that there is, unfortunately, within our society, this concept of the deserving and undeserving poor, right? Like that is something that we live with, right? While we around this table and in this room know that we all deserve access to healthcare, we also know that there is rhetoric that says we care about kids and kids having coverage. If family is losing coverage, it is more likely that the child will not have coverage. Are there opportunities for us to elevate the things that we like to hold up as values, and to be able to tell the real impact of those stories in ways that resonate, to be able to create more opportunity for the entirety of the issue to be resolved? So I was in a conversation around Medicaid specific to young people, talking about schools and talking about how you can see there'll be 500 young people that'll drop off of a roll in one day. That's not people, that's procedural. So where are those opportunities to tell those stories and to create some advocacy around strategy that addresses an issue that can have a larger impact in ways that feel like a win across the board, across the aisle.
Reese, I love that. I love that. And I think that is what we want to take away from this conversation is we want to get the information, but more importantly, let's talk about opportunities for strategy and how we can collectively advocate together. And Nancy, along those lines from Missouri Foundation for Health, Nancy Kelly posted that I just want to take a moderator privilege to highlight that that MFH and her team at MFH and her colleagues, they're hosting a group called the Medicaid Expansion Planning Group that meets monthly to discuss the latest updates, not only on implementation, but also how to discuss advocacy opportunities along what Risa was mentioning. And if you are interested, Nancy posted her email in the chat, and I encourage everyone to join those conversations and reach out to their team. In addition to the CHCM team, as we are always open and willing to hear from you on how we can support your advocacy efforts. And we have some great things cooking in the future. Specifically, currently, we have our Medicaid storytelling campaign that we're going to, again, highlight later on. But that link is posted in the chat for folks to share their stories and their ideas as well on how we can join together and advocate. With that being said, I do want to acknowledge a couple of questions so we can, and then try to sneak in maybe one more question before we open it up to our large group question and answer. So Asia, I'll turn it over to you to answer one or two questions related to what was just discussed.
Okay. How should nonprofit organizations who serve people who are going to be affected by these changes prepare to best serve their clients?
Yeah, I can start with the answer to that. I think the first is make sure you're at the table with these stakeholders at the state level so that you can clearly articulate, the needs of your clients, but also be willing to offer that education to your clients about what these changes are going to be and be willing to help provide support for direct assistance. I think direct assistance is going to be so big with these changes. It's going to be unlike a lot of administrative paperwork that families are used to and more frequent. But I think to prepare, start with the education piece, get involved with some of these groups at the state level so that you can speak for those populations that you serve, and then just be ready to provide that direct assistance.
And I would absolutely echo what Earlene said, but also say very plainly, advocate. Meet with your legislators, start talking with them right now, right away, and collect the stories. I'm going to share a story about something that I saw that was really effective in the legislature a couple of years ago. There were all sorts of school bus drivers who were laid off during COVID when schools were closed, and they were given the extended enhanced pandemic unemployment assistance, right, during that time. That assistance was overpaid because the state didn't make calculations correctly. And then the state sent all of these bus drivers who make about $20,000 a year in a good year, sent all of them letters saying that they had to repay $2,000, $3,000, $4,000, $5,000 to the state. And obviously they couldn't do it. And it wasn't because they screwed up as individuals. It was because the state screwed up. The state messed up the calculation. And they were being penalized and asked a year later to send money in that they didn't have. They all came together and state lawmakers responded to that. That story that impacted a whole bunch of people, and then exempted them from having to repay a significant portion of that unemployment assistance that they received. So, I would say it's just evidence of how strong people can be when they're working together. So bringing all of these groups together could create this huge power in impact and what happens as we move forward.
Thank you, Amy. Thank you. That hit home. Thank you so much. Asia, I'm going to pass it to you. We're going to try to get one more question in, and then before we turn it back to our panelists.
Okay, this question here again, I'm gonna actually try to tie in two questions in one. But someone wanted to, is it Lauren Stone wanted to shout out Earlene and her team for always helping those who have administrative issues with coverage and loss. And the question is, I'm guessing Show Me Healthy Babies coverage for people that are pregnant and not citizens will be impacted. Any plans to assist this population, which also kind of answers the question as well of, what is the impact for immigrants and refugees in the community? So if someone could kind of speak to both of those.
Yeah, I think, HR one of the big parts of that bill is the limits on coverage for certain non-citizen groups. I think we're still waiting for a lot of information on what those specific restrictions will be, but it's most likely to keep undocumented individuals from accessing like emergency Medicaid and then programs like Show Me Healthy Babies for prenatal care, but then also kind of tighten the eligibility by extending how long immigrants have to be residents before they can access benefits. Um, it's hard to say. I think a lot about Show Me Healthy Babies because we do help quite a few families access that program here in Missouri. But I think, again, we'll have to lean on those stories to raise advocacy on why that maternal health care is so important, and how that impacts the life of children from the time that they're in the womb. That's really going to have to be a strong form of advocacy for that group, but definitely something I can say that we will likely be looking at as well.
Thank you so much, Earlene. Go ahead. I'm sorry.
Oh, just real quick, and I know we want to move on. I think, Earlene did a great job of answering that on the Show Me Healthy Babies and other examples we could pull up. Many of these are state-specific programs that have been set up or sometimes by waivers. And I think it's really important that we protect those programs because, as we've mentioned several times, that you can't get blood from a turnip. So once this money starts drying up, the state may start looking at some of these optional things or some of these programs they've been doing, and we need to sort of protect it because it's really important that, a program that works like that needs to be protected.
Thank you, Tim. Thank you for that additional context. All right, everyone. So we're going to end our panel with this last question before we then transition into our large group Q&A. And I just want to assure you, if you put a question in the chat, we will attempt to get through to all the questions during our large group Q&A. We have not forgotten about you. We want to answer your question. We're trying to weave the questions as we're on topic on what we're discussing with our panelists, but we will do everything we can to try to get to every question that's asked. So with that being said, the last question I have for our panelists to kind of conclude this portion of the discussion is, what are some things that we can do? I know we've already mentioned so many things, but what are some things that we can do to help protect and support our safety net providers, our community health centers, our rural facilities as they face operational and financial challenges with HR1? That includes our nonprofits as well, those who are serving our communities that are impacted by this legislation.
So I will start, and I'm sure that everyone else will have something to add. But this is the time to do advocacy. The state legislature is not in session. Legislators are in their home districts. Folks who are working at nonprofit agencies or working at local healthcare providers, you should know your representatives, and they should know you. And now is the time to reach out to them and talk to them about what the impacts are going to be. And that is at every level, at the local level, at the state level, and at the federal level. Now is the opportunity, because when they're in session, it's very difficult to get a moment of their time. So I would urge everybody to make sure you're engaged civically and with your political representatives, so that they know who you are and what you do and how you impact your communities.
Yeah, I think it was said by Tip O'Neill many years ago that all politics is local. So I think that, it's important for you to tell your legislators, the House members, the Senate members, I think one thing I've noticed about this debate was interesting is there was increased awareness that, the number of people that are been affected by the Medicaid program directly. I think the number is over 50% of people have somebody in their family who is on Medicaid or has been on Medicaid. And just remind people that those people are in your community, and it might surprise people with that they're in rural Missouri or suburban St. Louis, or they're in, southwestern, wherever it is in Missouri, and how they're affected, whether it be an FQHC or a mental health provider. I think the misinformation I hear about sometimes about so-called able-bodied people are the ones that are only going to be affected, there's a lot of people being helped by the Medicaid program, including long-term care, the aged, the disabled. Just to point that out to your legislators, so they can be the ones that they get the first voice in getting the ear of the governor and the agencies to try to protect these programs.
The thing that I would say in addition to this is as you prepare to talk to your legislators or invite them to your facility or your nonprofit to take a tour and learn all about the work that you do, prepare your board. Make sure every nonprofit has a board of directors that is out in the community in different spaces. And those folks can have a significant impact, on helping the broader community understand what's going on, and then connecting with lawmakers too. So make sure your board is informed first, and then, invite the legislators to meet with all of you.
Yeah, and I would also urge folks, look for partners who may not be the people you're usually used to working with. And so when we're talking about impact on providers and less money coming into providers, that's going to affect all the businesses that are located around those providers. All the restaurants where the nurses from the hospital go to get lunch are going to be affected when there's fewer nurses working at the hospital. And you can just imagine those ripple effects. So create coalitions and alliances with those unlikely partners who may be those who are more likely to get an audience or get the ear of a legislator or a policymaker.
And I agree. I think partnership is going to be so essential, even though we all separately work in spaces where we can hear those client stories and importance. We need to probably come together so that we are elevating more voices, as many voices as we can, so that they can get to the right ears who have the ability to make that change.
Great answers. Great answers by everyone. Thank you for those ideas, those affirmations, those encouragements to our community. And I think that's a great segue to lead into our large group discussion. But before I do that, I do want to answer one question from the chat before we go into that large group conversation, and I'll pass it back to Asia to ask that question.
Okay. One of the questions is, it's been observed that some statewide organizations have established barriers to entry for some providers. Some believe these barriers protect resources to the existing members, but I would say they lose the expanded voice that would come from a more diverse membership. Any suggestions on getting councils and statewide organizations to be more open to diversifying their membership?
Can I ask a clarifying question? I'm assuming that these are networks of providers.
Well, and to be honest, this person was anonymous, so I'm not sure. any additional context to this question. So
I have heard this. I will say I have heard something similar from some healthcare providers, that some networks of healthcare providers are fairly closed off. So, I don't have suggestions for that. I do want to reiterate, like, now is the time for everybody to be working together. So if you run into a barrier with some,
Amy,
yes.
I didn't want to cut you off, but Missouri Behavioral Health Council as an example.
Okay. Yeah, I think that now is the time for everybody to be working together. So I would clarify that with whoever is creating the barrier, right? I would just straight out have a conversation with them about, can we partner better? Can we be inclusive and see if you can get anywhere.
To that end, Amy, I'll take another moderator privilege. Are there any Missouri politicians, someone in the chat wondered, that would be receptive to this message? I know our own Senator Hawley has some proposed legislation regarding Medicaid in the state of Missouri.
So I think that these are messages that need to be made to all the politicians in Missouri. I mean, on the one hand, we can look at how they voted on this bill, and we didn't get a whole lot of support. That doesn't mean that they can't be swayed in the future. That doesn't mean you shouldn't be weighing in. Senator Hawley is a good example. He said a lot of things about why he wasn't going to vote for this bill before it was passed, and in the end, he did vote for it. But he's also trying to say, well, I want to roll some of it back. So if he's giving us an opening, let's take it. But let's not only focus on Senator Hawley. All the reps in Congress, Jason Smith is a great example in the 8th District in Southeast Missouri, very powerful member of Congress, chair of the Ways and Means Committee. He's going to have a say in how all this plays out. So folks should be talking to him if you're in his district. And the same goes for your state reps and your local representatives. You should be talking to all of them about what the impact is going to be on the people you work with and on the services you provide and on your communities.
And I'll just throw something in as from my experiences working as chair of WellHealthNet. Is, I think it's, if you have a specific example and you bring it directly to the agency heads or whoever's in charge of that, we're not talking about the legislature now, we're talking about people in the departments. And that sometimes you can get that's a good way to get a response, because the number of times I, as chair, got specific questions about some barrier that was thrown up, and then I threw it back to the agency, and they worked on solving that. I don't like this sort of piecemeal approach, but it definitely it might elucidate to them a problem that they need to work on. And I think we have some very good people in some of those agencies that can try to do the right thing, and they can maybe lean on the politicians.
I think something related to this, somebody asked in the Q&A just now, and Asia, I'm jumping into your arena here, so I apologize. But somebody asked about talking points, and I will say that there are a number of advocacy organizations that are working together right now to come up with a plan. And we will have talking points on the revenue aspects of this and the budget aspects, and how to navigate those conversations. And then I know MFH always has good talking points too on the health implications. So we can pull all of that together and share it out with folks.
And one thing that relates to Amy's point, I just thought of this, and earlier somebody had asked a question about the timeline. If you look at that timeline, if you follow that, and if that ends up being followed, we're talking about, this is not a fight that's over. This is a fight that's just started. It's going to go on till 2028 or beyond, and all the pieces of legislation have dates that go out to like 2030. So I hate to tell you, but this is a long-term fight, and it's don't give up. I think sometimes I've seen people fight for a piece of legislation, and then it either passes or fails, and then they move on. But I think the implementation phase is almost as important or more important than the actual phase of advocating for a certain piece of legislation, because we a lot of times you don't get what you want, but you can get it in the implementation phase, because you can go, wait a minute, you have a power as a state agency or a state legislature to tweak this and make it to work. And I just see Sheldon put that implementation is 90% of the battle. I agree 100%. So keep that in mind. The fight's not over yet.
Love that. The fight's not over yet. That's a rally call, Tim. The fight's not over yet. Let's say it all together.
The fight.
The fight. Oh, Tim, I appreciate you. You a man after my own heart. I was rhetorical from that, but I do appreciate you nonetheless. All right. With that being said, I think we've already kind of moved into our large group discussion. We'll take the next, let's call it 10 minutes to answer any more questions from the chat. And if you haven't asked a question yet, now's the time to do it. If you've been motivated or sparked by anything that's discussed, please put your question in the chat. We would love to hear from you. With that being said, Asia, I'm going to turn it over to you.
Okay. The first question is, what state-level advocacy efforts and safeguards regarding Medicaid coverage to ensure expanding access, ensuring benefit adequacy, and addressing potential cuts and restrictions are your organizations involved in doing?
Oh, you're putting us on the spot. That's great.
Well, I'll start. I mean, first of all, we're all working together. I think I mentioned earlier that we see each other in Zoom boxes probably several times a week to try to figure out what sort of information is needed, what kind of resources folks in communities need to do this work, and talking to each other and to partners about that. And so at MFH, we fund advocacy organizations who are on the ground doing this work. We fund research that looks at the impacts of this. We try to be good at being a convener of folks to bring people together to do this work. And I will let my other panel members talk about kind of their pieces of that pie.
And, I sit here in this ivory tower that's sitting behind me here. And so sometimes people wonder what the universities are doing, but I consider it, and I think you know me, that I take it's a privilege to be a professor, especially a full professor. So we have the duty to speak up and to do the research. So if we get asked questions, we will answer them, but it goes beyond that, I think, because as you know, we train social workers and we train public health workers, and they are the legs in the community. But, of course, we're connected to one of the biggest providers in the region, and I know that they are listening and they're paying attention to this, and it's going to affect them quite a bit too. So, if they're not very vocal all the time, believe me, they're paying attention, and it's going to fall on the universities who are often affiliated with health systems to sort of implement this situation. And I know they've been asking those questions behind the scenes. And believe me, I will keep pestering them with what we learn.
And I will also add that we have a relatively open Thursday Zoom meeting. It's weekly during the state legislative session. It's been bi-weekly this year outside of the state legislative session. So those meetings are open to any advocates. And one of the things that we're working on is really partnering with the organizations that participate in that, and others, to develop an advocacy plan. So we will be continuing to advocate on Medicaid throughout, years and years, throughout the years. But if you are interested in getting those emails and participating in those Thursday Zooms, just shoot me an email and I'll stick my email address into the chat.
Yeah. And just to add, as already stated, we all do work together across many committees and see each other often on Zoom, but at Legal Services of Eastern Missouri, as many of you know, we do provide that direct assistance in the community. We are also at the tables with our stakeholders, being advocates for the communities we serve. We serve under the great leadership of Joe Ferber with Advocacy, and he helps us lead a lot of our work. Many of our attorneys, as well as our non-attorney advocates, are hitting the ground running, looking at what these systemic issues are, what implications many of these new changes will have, preparing to do comments and things. But we are continuing to serve on those various committees to elevate the voice of the clients we serve, and also being a support to our partners, offering technical assistance, training, however we can help. So.
Great. Thank you all for those answers. Asia, next question.
This one is more like a statement. I want to make sure I'm saying their name right. Is it Antaki Arasa? And they say that my question is oriented towards navigating what we can do. It's not really a question, just a thought. I have been thinking about doing something to completely demystify this budget and how it will affect most of us. I especially think we need to create engagement and awareness among those who are not Medicaid recipients, who think that this atrocity of a budget is not their problem, so that, like Sheldon said, we can do something. I would love to collaborate with anyone interested in opportunities to raise awareness and create base for an organized movement.
So let me just add, I will prop for Amy here. I think that is a perfect comment of someone. If anybody out there feels that same way, joining the Budget Project's Thursday calls is a great way to get engaged with a large number of folks who think the same and are working hard to figure out how to organize to make these changes.
Amen. Can say it much better than that. That's the place you should go if you want to learn about the budget.
I agree. Tim, mic drop, Sheldon. Great response. And again, just to echo, Amy and her team do a great job with highlighting information, keeping us informed. We just had a call yesterday. They just had a call yesterday where they provided us with a wealth of information and also told us about some exciting things that they have in the works. Amy, I don't know if this is if you want to share a little bit of that, or is it too soon about some of the potential resources still? Is it too soon? Okay, too soon.
No, it's not. I'm not thinking, but that's only because I'm agreeing with what you're saying. No, it's not too soon. I'm happy to share. I always share things when it's too soon, or so don't tell me any secrets, because I'm not good at that. But and Sheldon just said in the chat, the calls are group therapy, and I totally agree. I use it as those each week. But we are, one of the things, as I mentioned, I keep talking about the budget struggle, and part of the issue is that, we cannot in Missouri fund all of the services that we need to fund without really looking at our revenue structure. Really, that means looking at our tax structure. And so one of the things that we are doing is working with different grassroots partners on developing and holding tax town halls. And these town halls are going to talk about, what's happening at the federal level, what's happening at the state level, kind of pulling it all together and really looking at, these investments and services require funding. And we have, over the last decade in Missouri, reduced our revenue by $3.5 billion through tax cuts that largely went to the wealthiest Missourians and at the expense of everybody, So if we want to protect Medicaid and other services, Medicaid, SNAP, education, everything that provides a foundation for people to thrive, we need to move a revenue solution to the ballot. And we're going to start, the first part of that is really starting to have conversations in communities. So we'd love to work with everybody to create those conversations. Robert volunteered, and if he didn't get an email today, he's going to get it by Monday, about helping us communicate all of this stuff with real people rather than some of the more academic language that we tend to use. So, we're really looking at all of you to help us with that.
If I could add one thing to all the great comments, it's, at the helicopter level, what this bill did was it took $1 trillion out of the federal projected budget and more and shifted it to the states and basically said, it's your responsibility to figure this out. If you want to cut the program, cut the program. If you don't, find the revenues. And, I think people just sort of need to think about that at the helicopter level, because that's kind of a mind-boggling sort of, shifting of the role from federal to state governments. And so it's incumbent upon us to just sort of remind us. I feel bad for the state legislature and the governor that they have to handle this going forward. And one other quick thing, I always like to throw this in there. We're in the middle of the retirement of the baby boom generation, at which I'm part of. So if this, just keep in mind, I see in the chat many times, I just sort of acknowledge it. A lot of mentions of the long-term care, of the elderly, of the disabled population. We are in the middle of a doubling of the aged population in Missouri. And as the population ages, they're going to be using more long-term care. And over half of Medicaid spending goes to the aged and disabled and blind. And if you're trying to cut spending, that at some point you're going to start looking at that. And we do not want that to happen as we are aging. And, so these are your grandparents. These are your people that are, have disabilities and can't afford medical care. So, that message needs to get to our leaders.
Excellent. All right, I'm going to try to sneak in one last question, Asia, before we close it out. So I'll give you the privilege of picking that last question.
I feel like a few of the panelists may have spoken to this, but I'll just ask this question again. Will any of the organizations represented by our panelists be provided talking points for specific advocacy efforts at the various levels of government? Example, talking points for the state legislators on funding the state agencies and systems needed to do the work.
I think you can see us all nodding. So that is one of the things we're all working on, and one of the things that Amy is leading as part of the efforts she was talking about. So yes, and I want to add something also that these days almost seems trite, but is fundamentally really important. You have to be registered and vote. MFH and several of our other funding partners from around the state were engaged in an effort last year to register voters. Incredibly successful. What we weren't successful at was turning those registered voters out to actually vote in the election. And that is something that, a lot of people think, why bother? What difference does it make? It's very easy to feel that way as an individual. But when we collectively go out there and do it, that's what makes a difference. And ultimately, that is going to be the only way to change all of this.
Absolutely. And I would just, this is another issue to just keep an eye on, is that President Trump and it's urging all state legislatures to redistrict congressional seats right now. We usually do redistricting every 10 years after the census. And so this is highly unusual. And it is about gerrymandering the districts, the federal districts, to make sure that Congress retains Republican control moving forward. So I think pay attention to that. That is something that state lawmakers are talking about bringing up during the September veto session, or concurrent with the September veto session, which is not far from now. And, talk with your state lawmakers about how you do not want that to happen. We should not be redistricting outside of the normal process just because it's, a certain president wants that. What this means, and I think you're talking with Republican lawmakers, one of the things to say is it means that anybody who's in charge at the time, Democrat or Republican, could do the same thing. So it sets a precedent that they do not want, really, whether they're Republicans or Democrats.
Thank you. Thank you all for those closing comments and answering our questions. I think we got through almost every question, if not every question today. I am truly impressed. Big shout out to Joy and Asia, my colleagues at the Community Health Commission, for all of their vigilance with answering the questions. Again, our panelists did a great job, per usual, of answering the questions and multitasking. Truly, truly appreciate you all for answering the questions. And thank you to our audience for for asking those insightful questions and really wanting to get the information and resources you need so that you can assist in your advocacy efforts. With that being said, I'm going to pass it back over to our CEO at the Community Health Commission of Missouri, Risa Rollins, for closing remarks and any final comments. Risa?
I have 1 minute to wrap because I'm the thing standing between you and your weekend. So again, just want to give deep gratitude for y'all for participating. Thank you, thank you, thank you to our panelists for your leadership and your insight. All of you who were able to attend, and those of you who stuck it out to the very end, thank you for your presence. Thank you for your questions, your active engagement. Again, WashU, CHCO members behind the scenes that are clicking all the buttons and reading all the things and keeping us together. Thank you again. So today made it clear that it's not just about policy, and that is the punchline that I will continue to drive home. It's deeply personal. The fight for Medicaid is part of a bigger fight for health justice, and that's what we stand 10 toes on. We are not powerless. We have knowledge, we have community, we have voice. And so if you walk away with anything, it's not going to be doom and gloom to start your weekend. It's going to be feeling like we have community and we have an opportunity to make a difference. So how are we going to do that? Glad you asked. CHCM is continuing our Medicaid storytelling campaign through our eyes. We know that stories matter. So we're going to continue to collect and share real stories of Missourians impacted by Medicaid policies. You could see that link in the chat. Our team has been sharing that ongoing. If you or someone you know has a story to share, we want to hear from you, whether it's from a provider's perspective directly, whether it's from someone who is helping folks navigate, or if you yourself know or are navigating the systems. Stories change hearts, and sometimes they change laws. And so that's what we're here for. Please also complete the post survey link, because we're all about that data, but no numbers without people, no people without numbers. The data helps us understand what's important, the conversations we want to continue to have, and it strengthens our impact in spaces and expands our reach. You're not alone in this work. We're moving forward together. I saw someone ask very early in the conversation, so what do we do? Just sit here and take it? Oh, we never do that. But thank you for being part of this growing movement. We're going to fight till the very, very bitter end, and we're going to work towards health equity in our lifetime. So stay connected, stay vocal, stay in community, go get some well-deserved rest and respite, spend time with those you love and those who fill you with joy. Again, thank you very much and have a wonderful weekend. And we end this, y'all. We end this together.
Risa, it was unintentional to give you that short amount of time, but it was beautiful to see you do it so well. So thank you for wrapping this up with this conversation. Again, big shout out to the WashU Brown School for hosting. Again, we really are appreciative of your partnership. another thank you, I can't say it enough, to our wonderful panelists, Amy, Earlene, Sheldon, and Tim. Thank you for being here. Thank you for standing with us. And to our audience, as Risa said, thank you for taking time out of your schedule to have this important conversation. Please take care of yourselves, get some rest, but let's continue to fight together. Stay tuned for more, and we will be in touch. Have a great weekend, everyone.
I was just going to say we should have Risa closing out all our meetings.
Yeah,
Absolutely.
Then we can just take that little clip and just plop it at the end of every meeting we have. That'd be great.
Great. I love you, Sheldon.
Thanks, y'all.
Thank y'all.
Bye.
All right.
take care.
Have a great weekend, everyone.